Hi guys, we're still in week 7 cardiology. Now we're going on to part 2 of our PowerPoints. In this particular PowerPoint, we're really going to talk about AFib and some different the heart blocks. All right. Okay, so atrial arrhythmias. So we talked about in our last PowerPoint how to identify an arrhythmia in terms of the 12-lead EKG. So let's just get a little bit more into the atrial arrhythmias. So we're going to look at the premature atrial contractions, the PACs. In these particular PACs, these patients definitely present with complaints of palpitations. That's really what you're going to see in premature atrial contractions is palpitations. Treatment includes stopping smoking, cutting out caffeine, managing the fatigue, cutting out any stimulants, and keeping an activity diary to know when these palpitations are occurring, just so we could get an idea of, okay, are they really, the palpitations really occurring with activity? And in these particular patients, to really get a good grasp on the PACs, you may want to consider Holter monitoring at home. We also have atrial tachycardia, where we have a P wave rate of 140 to 250 per minute. We have a flutter, which we looked at that EKG strip in our last PowerPoint, which is less common than AFib. Often organic, it's often organic heart disease, and in that you'll see the P wave rate of 250 to 350 beats per minute. And obviously we know that atrial fibrillation or AFib is very common. Okay, atrial arrhythmias and re-entry. So in supraventricular tachycardia or SVTs, if we leave it untreated, or often if it's treated, if sustained, patients tend to decompensate. So in SVT, you usually are going to see this presented typically in younger women in their 20s. Certain things that can cause it to improve are vagal maneuvers and adenosine, which is provided in the emergency room. It's definitely greater in women than men. And it's often symptomatic in that they feel palpitations, they feel their heart is racing, they may get some dizziness, and it does bring on some chest pain at times. So what we really need to do is make sure we're differentiating, is it SVT or PSVT? And PSVT being paroxysmal, meaning it's episodic and not necessarily sustained. Okay, so SVT versus PSVT. PSVT is paroxysmal, which means it's episodic, and not necessarily sustained. There are multiple forms of SVT, okay, or supraventricular tachycardia. So we have atrioventricular nodal reentrant tachycardia, AVNRT, and orthodromic circus movement tachycardia, CMT. So we have this thing, we call it the frog sign. It's a classic sign where you'll see the patient flapping, pulsating, bulging appearance of the necks due to the retrograde depolarization of the atria and higher atrial pressures. And this can be particularly helpful in making the diagnosis of your typical AVNRT. So again, that frog sign is the flapping, pulsating, bulging appearance of neck veins. That's a very classic sign of your AVNRT. So remember that. Anytime you think of AVNRT, think of the frog sign. Flapping, pulsating, bulging appearance of neck veins. Okay, so in AVNRT, we want to differentiate. The P wave on your EKG, you want to make sure you're differentiating that the P wave appears immediately after or just within the QRS complex. You may often see a pseudo R wave, which is seen in lead V1, and a pseudo S wave in leads 2, 3, and AVF. The retrograde P wave represents retrograde activation via the fast pathway, and the onset after a premature atrial beat with delayed conduction to the ventricles. In an AVNRT patient, we're treating them with beta blockers, and a lot of the times, 95% of the times, actually, ablation is successful in treating AVNRT. Okay, WPW, a reentry tachycardia. It's an accessory pathway. It happens greater in men than women. It's not familial or genetic. The etiology is actually unknown. We're looking for a delta wave or a slurred upstroke in the QRS complex, often associated with a short PR interval. In treatment of this, we're looking at antiarrhythmics, digoxin, cardioversion, and ablation. You want to avoid common treatment for SVT and tachyatrial arrhythmias, adenosine, diltiazem, verapamil, and other calcium channel blockers and beta blockers, hence the need to rule out prior to treating for SVT, okay? So in WPW, we have a very short PR interval, QRS prolongation, and a delta wave, which are hallmark features of WPW, also known as Wolff-Parkinson-White syndrome, WPW. It's a mouthful, so just stick with WPW. It's easy to remember. Okay, in terms of the treatment, you want to collaborate with cardiology, obviously. You want to make that referral. You want to get an EKG, you want to get labs, a drug screen, an echo, an EPS lab, ablation, and you want to continue to work with cardiology and, to see if they need further testing, like a stress test. If they tend to have acute episodes, the treatment will be Valsalva maneuver, carotid sinus massage, splashing of cold water, ice water on the face. You want to consider antiarrhythmics, but just be careful with drugs like adenosine because that actually may be contraindicated and may worsen the WPW. Okay, ventricular arrhythmias. So again, we're talking about PVCs, premature ventricular contractions, usually benign, they're transient. You want to treat the underlying cause. So we want to give them oxygen. We want to make sure everything's in balance in terms of their electrolytes. We want to make sure that there's no ischemia going on. And in ventricular tachycardia, we can decompensate quickly, right? So we definitely want to make sure with VTAC, we looked at that strip before. Remember, we said that means trouble. We want to just make sure that we have ACLS, and we're ready to go in case they do start to have an MI. Okay, and of course, we want to try to get them antiarrhythmics because the idea is when you see that EKG strip and that patient's in VTAC or ventricular tachycardia, remember, they can decompensate very quickly. We're talking minutes. So the minute you see that, you're calling a code, okay? We want to look at ventricular fibrillation, which again is the worst. It's not compatible with life. Again, we're going to start CPR and initiate ACLS. And then we have our heart blocks. So we have first, second, and third degree heart blocks, which can be associated with medications such as digitalis toxicity, ischemia, infarction, and conduction issues. So this PowerPoint has a lot of review of what we just reviewed in our last PowerPoint. So I think it's good because it just reinforces what we just learned before, especially in terms of looking at these particular things on an EKG strip. So we'll look at our three different heart blocks. We have first degree AV block where we have a prolonged PR, usually asymptomatic, does not require really any prescriptions, but we do want to look to see if any medications that they're currently on may be causing the heart block. Second degree, Mobitz 1 and 2. Okay, Mobitz 1 is a prolonging PR, then a drop. You want to assess for beta blockers, DIG, and other meds. You want to assess for the inferior wall MI, and you want to start pacing if they do become symptomatic. Mobitz type 2 is actually that there's too many Ps, and you may go into a third degree heart block, and it does require pacing. So you want to collaborate. You want to get a cardiac consult immediately. They're going to be considering transcutaneous or permanent pacemaker. And then, of course, we have third degree or complete heart block, which is bradycardic. They're often symptomatic. It's an emergency. They require a pacemaker. If you're in a primary care setting where you're seeing third degree heart block, you need to begin BLS and ACLS immediately and arrange for transport to an emergency department. Again, when in doubt, don't hesitate, call 911. It's better to have a group of people to figure out what's going on with the patient than trying to figure it out alone and not have the correct stuff that you need to help treat this patient on hand, whether it's medication or, your cardiac life support things. Okay, so again, I love my little quick videos that give a nice visual demonstration of what it is we're talking about. Here is a heart block review around the EKG, just to give you a comparison.
In this video, I'm going to be teaching you guys about the 3 types of AV blocks that are very high yield for step 1. Basically, on step 1, the test writers know that you cannot interpret EKGs because you're really just beginning in your kind of clinical path. So there's only a limited number of EKGs that are fair game. And because the pool is so small, AV blocks are so high yield. Because again, aside from sinus rhythm, AFIB, or A-flutter, the 3 AV blocks are really, really fair game. So you're probably going to be asked a question on them. And that's why they're high yield, and that's why we're going over them today. So before we go into the AV blocks, here is normal. You have a P wave, a QRS complex, and a T wave. What we're going to be concerning ourselves with today is really the PR interval. That is the distance from the beginning of the P wave to the beginning of the QRS. Now, normally, On a normal EKG in normal sinus rhythm, the PR interval is less than 200 milliseconds, which is 5 little boxes on an EKG. In this example of normal, it looks like we've got about maybe 3.5 to 4 blocks. So this is normal. If it was greater than 5 blocks or greater than 200 milliseconds, then it would be prolonged and we would have to think about an AV block. So again, this is normal. So we're going to start with the first degree AV block. And before I do that, I just want to say what it is and what the presentation will be on the exam. So an AV block is just as the name implies. It is a block in the conduction system down from the SA node to the AV node, so the His-Purkinje system never gets activated correctly, and therefore the heart can't beat efficiently. So think about it. On the test, you might be given a clinical vignette where a patient is experiencing dizziness, syncope, a slow heartbeat. Whatever the case is, it's all related to the fact that the heart can't squeeze and give you that nice good ejection fraction in time because of the electrical conduction abnormality. So a first degree AV block looks like this. And basically what you have in a first degree AV block is just prolonged PR intervals. They are constant, they are prolonged, and that's it. So whereas in the normal, I showed you a nice pretty little PR interval that was less than 5 boxes, a first degree AV block is a PR interval that's greater than 200 milliseconds or greater than 5 little boxes. And I've drawn in these reddish arrows to illustrate that to you. Now for second degree AV blocks, there's 2 types. The first one is called Mobitz 1, also known as Wenckebach, and the second one is known as Mobitz 2. Now you do have to know the difference, but I have a nice little memory hook or mnemonic for you that'll help you out. A Wenckebach looks like this. And what happens is the PR interval gets progressively longer before a QRS is dropped. So usually there's about 2 to 4 beats and then you drop a beat or you drop a QRS. So what we see here in the example, and I've again drawn in those little red arrows to show you, is that PR interval lengthens, gets longer, and then you drop a beat. Because the conduction abnormality, you conduct, the heart's trying to squeeze and the signal goes through delayed. Heart tries to squeeze, the signal goes through even more delayed. Same thing happens, and then the signal never makes it down to the His-Purkinje system, and you never get that QRS, which represents ventricular depolarization. So the way that you remember this is longer drop, that is a Wenckebach. Longer drop, that is a Wenckebach. Okay, so what you're looking for in Wenckebach, again, the PR intervals are still greater than 200 milliseconds because they're prolonged, but you're getting PR intervals that are progressively elongated before a beat is dropped. That is Wenckebach. Another way to remember this is some people say Wenckebach gives you warning. Just think of those W's. Wenckebach gives you warning. The PR intervals are gradually lengthening and they're warning you, yo man, I'm about to drop a beat. Check out my EKG. That's Wenckebach. That's also known as Mobitz type 1. Now Mobitz type 2 is a little bit different. In a Mobitz type 2, the PR interval is lengthened. It stays lengthened. It's not getting progressively longer. They stay elongated, but then a beat is dropped. So the way that you can think of a Mobitz type 2, it's almost like a first degree AV block that has a dropped beat in it, because the PR interval is still greater than 200 milliseconds and it's still constant, but somewhere downstream you drop a beat. Now look in the example here, that green down arrow shows you where a QRS complex should be, but the beat is dropped. Meanwhile, the PR interval is still lengthened, as you can see by the green little ticks. That's a Mobitz type 2. So again, Wenckebach gives you warning. Longer drop, that is a Wenckebach. Mobitz type 2 is just a prolonged PR interval that drops a beat. You need to know the differences, but these are just 2 subtypes of a second degree AV block. Now, the last one we need to talk about is a third degree AV block, and I've dedicated an entire slide to it because it's really important that you be able to pick this out, because this is probably the highest yield in my opinion. So a third degree AV block is one where the atria and the ventricles contract independently of one another. They both work, they both squeeze, but there's such an abnormality in the conduction system that they basically say, I'm just going to do my own thing. So the atria are squeezing, the ventricle are squeezing, and there's no connection between them. Now, because of this, the EKG has a very characteristic finding. What you'll tend to see are a couple things. First, constant P to P intervals and constant Q to Q intervals. What does this mean? So even though the atria and the ventricles are contracting independent of one another, the interval between themselves is still constant. So let's look in the second EKG strip I have on this slide. Look at the bottom arrows where you see the P waves. They are all at constant intervals. Even though the atria are doing their own thing like little rebels that they are, they're constant. Look at the intervals, P to P to P to P to P. It's all the same interval because even though the atria is doing its own thing, it still has rhyme and reason to it in itself. Look at the top where the R waves are. They're still at constant intervals. Even though they are beating independent of the P waves, they are at constant intervals. Now, that's very characteristic of a third degree AV block. The other thing that's very characteristic that you have to keep in mind is that because the P waves and the QRS complexes are going to be appearing independent of one another, it's possible that P waves are buried within QRS complexes, and it might be hard for you to find P waves. So if you look at the first strip on this slide, in some of these examples, it looks kind of funky, right? I mean, we can't really discern P waves, QRS, and T waves. The reason that this is because you're having some overlap, if you will, where the P waves are almost entirely buried in the QRS complex. Look at the second QRS beat in the first rhythm strip. You see that little thing right in front of it? That's a P wave that's basically buried in the QRS. Now, this is kind of easy to spot because I pointed it out to you. But on the test, it's possible that you're given a rhythm strip. They're going to be bradycardic, again, because it's an AV block. The patient's going to have dizziness. Maybe they fainted, whatever. And then they show you this weird strip, and you're like, I don't know what this is because I don't see P waves. These are really big, long QRS complexes. What the hell am I looking at? Just relax. Look at the intervals. If the P to P is constant and the Q to Q is constant, you're already on the right path. If you can't find P waves, maybe they're buried in the QRS complexes. If that's the case, you've got yourself a third degree AV block. So now let me just summarize what we've gone over today. AV blocks are conduction abnormalities in the heart where signals are not properly propagated down from the SA node through the AV node into the His-Purkinje system. Because of this, people with AV blocks experience bradycardia, dizziness, and syncope. A first-degree AV block is one such that the PR interval is greater than 200 milliseconds or greater than 5 little boxes on an EKG. There are no dropped beats in a first-degree AV block. In a second-degree AV block, there are two types. The first type is a Mobitz type 1, also known more commonly as a Wenke Bach. In a Wenke Bach, the PR intervals get progressively longer before dropping a beat. On EKG, the PR interval will be greater than 200 milliseconds and get longer for a few beats before a QRS complex completely disappears. The mnemonic to remember this is that Wenke Bach gives you warning, or longer drop, that is a Wenke Bach. In a Mobitz type 2, the PR interval is greater than 200 milliseconds. It's constant. It doesn't get progressively longer. It stays elongated, but then you drop a beat. A second degree AV block is basically like a first degree AV block with a dropped beat. And lastly, a third degree AV block, as you see here on this slide, is one where the atria and ventricles are contracting independent of one another. The P to P intervals are constant. The Q to Q intervals are also constant, but because they are independent of one another, oftentimes the P waves are buried in the QRS complexes, and it makes EKGs really hard to read. Because of this, these are high yield. All right, guys, go through this once or twice. It's high yield. It's going to be helpful, and I wish you the best of luck.
And by high yield, he means it's definitely going to be a question that is fair game on any of your exams because they are so notoriously dangerous to have these heart blocks. And as practitioners, we really need to be able to recognize them. So, sorry, guys. Okay. Oops. Okay, sorry. Okay, so we've reviewed our heart blocks. All right, so here we go. So here we have our strips again. We talked about this in our last PowerPoint. We have AFib and A-flutter. Okay, these are common arrhythmias that you need to make sure you're able to be aware of or recognize. We have PAC and PAT, which is our atrial tachycardia. We have SVT sustained and PSVT paroxysmal. So here's our SVT sustained, and here it is paroxysmal, meaning it comes and goes. We have ventricular heart blocks. So in ventricular heart blocks, again, we're going to just talk about the same thing again. First degree AV block, which is a regular rhythm and a prolonged PR interval. Then we have second degree AV block, which he just talked a lot about, which is type 1 and type 2, Mobitz 1 or Wenke Bach. which is initiated at the AV node, and it has a progressive lengthening of the PR interval unit at QRS complex. And then we have type 2 or Mobitz type 2 within or below the bundle of His with a normal or lengthened PR interval and a periodic drop of a QRS complex. These are much easier. These blocks are much easier to understand, especially when you're looking at the video like I just showed, and they're demonstrating how the EKG strip looks with that particular block. It's much easier to remember it that way. So I would encourage you, when you're studying and you're trying to review these things, really look at your arrhythmias or your blocks based on the EKG strip, okay? That way you can really get a visual memory bank of these particular arrhythmias that are very dangerous and can lead to cardiac arrest. So here we have ventricular ectopy with our PVCs, with a single PVC versus multifocal PVCs. More strips of examples. We have VTAC, torsades, and VFib. All of these equal emergencies. We have our heart blocks. Again, we just reviewed this again, but here we go. So type 1, type 2, type 3. Remember Mobitz type 2? Think too many P's. We have heart block and bundle branch block. So there's no relationship in this particular strip. There's no relationship between P and QRS. Likely an emergency. In this particular strip, it's a bundle branch block, and it could be a left or a right because we do have a wide QRS here. That notched QRS tells you we have a bundle branch block. Okay, in terms of arrhythmias and just making sure we're getting the basics. So a general arrhythmia assessment and management. So basic stuff, subjectively, we're looking at the patient and what are we seeing? We're seeing palpitations, dyspnea, chest pain, loss of consciousness, possible syncopal episode, definitely could be fatigued, especially in AFib. Sometimes in AFib, though, they are asymptomatic, while others who have gone into AFib without even knowing it may have already had a CVA or a stroke, and then we're identifying AFib at that time, which is unfortunate because, you know, the damage is done now. Objectively, what are we looking at on the patient? We're doing an overview of their skin. Do we hear any cardiovascular murmurs? S3, S4, do we see any jugular vein distension? Do we see edema? How are their pedal pulses? Do we have signs and symptoms of heart failure? Respiratory, listen to their lungs. Do you hear rails, crackles? Even when they cough, how's that cough? Is it a deep, wet cough? We know we're in trouble. Neurologically, what is their level of consciousness? Are they exhibiting any confusion, agitation, anxiety? How is their GI status? Do they lose their appetite? A lot of the times when these patients are at this point, they can't eat because they don't have the energy or the breath or the desire. And also, how's their urine output? Are we looking at less than 30 cc's an hour or more than 30 cc's an hour? Again, the treatment for any general arrhythmia is you want to just go ahead and call 911, initiate ACLS for emergency treatment. We obviously have already tried to get a cardiology referral or consult in place. That's a number one thing you're doing. We want to administer antiarrhythmics, consider a pacemaker, consider cardioversion or ablation, an IACD, and of course, we want to make sure they get regular follow-up. These patients, especially after all is said and done, require a lot of education and support. You want to make sure you're educating them on medication management, the importance of taking their medications every day to prevent further episodes of any kind of cardiac decompensation. We need to make sure they're getting their blood draws for their INR. You need to explain to the patient about INR, about being on blood thinners, the things they need to be looking out for, the dangers of having too much blood thinner in their system, when they need to call 911 or their practitioner. A lot of education with these patients, okay? Because the idea is these patients are so frequently rehospitalized, and one of the things we see many times, a lot of the times, is that it's just due to improper medication management and just lack of knowledge in order, you know, in terms of like when they needed to call. You definitely want to get into dietary restrictions and give them support in terms of any stress or fear they have in terms of their diagnoses. Okay, AFib, one of the most common arrhythmias. Remember, atrial kick is 15 to 30% of your total cardiac output. Without the atrial contraction and contribution, some patients become hypotensive, diaphoretic, they get chest pain, and they become hemodynamically unstable. The causes of risk of an embolic stroke is very great, is greater after 48 to 72 hours. The ventricular response in AFib is often, you often see this term used with AFib. Only a portion of the P waves in AFib conduct and cause a ventricular response. Otherwise, with P wave rates in the 2 to 300, the heart ventricles could not sustain beating that fast. With AFib, we're always putting them on anticoagulation therapy, which should be initiated in all patients who remain in AFib for longer than 48 hours or who experience AFib of unknown duration. You want to use the CHAD scoring, or it's also called the CHA2DS2, VASC. It's an evidence-based tool that you definitely want to use in terms of determining their risk. So it's more inclusive. So if they have any of these things, they get a point for each one, and that'll give you a score on their risk factors. So it's used to determine the risk for stroke and treatment in AFib. It's you want to make sure you use the appropriate CHAD. This is the NUR assessment, which is more inclusive of risk factors in females, and it is the most up-to-date evidence-based practice tool. So you want to make sure you're using the right tool. You want to tally up the points to determine the risk, and then you want to interpret it. So men score at least 1 point, and women who score at least 2 points should be started on oral anticoagulants to reduce the risk of stroke. So this scoring tool is literally used just to figure out like how high of a risk they have for strokes, and do they need the medication. And it's pretty basic. I mean, you definitely want to use it just to document that this is why you started the patient on an anticoagulant, just to back up your diagnostic findings and treatment plan. But once you get used to the tool, you'll just take one look at your patient and their history and know whether or not you need to be prescribing. In order to interpret CHAD, you want to get a score of 2 or greater, and an oral anticoagulant is recommended. And obviously, in terms of oral anticoagulants, we're talking about warfarin, dabigatran, rivaroxaban, or apixaban. A score of 1 would be an aspirin or an anticoagulant. A score of 0 would be an aspirin or no treatment. When it comes to an aspirin or no treatment, you definitely want to look at their age, their comorbidities, and any other risk factors to determine if you really don't want to put them on an aspirin. So this also can, give you a prediction of the risk of stroke. So it's used to determine treatment. It's also used to educate, if the patient has a high risk for stroke, this is obviously where you want to take some time to educate the patient about the risk of stroke. So if a patient has a score of 4, they have a 4% annual risk of stroke, or 40% risk over 10 years, okay? As a general rule, regardless of scoring, patients with AFib caused by valvular heart disease or severe mitral regurgitation or mitral stenosis, anticoagulation should be utilized. Okay, so the goals in treating AFib is to relieve the symptoms and the quality of life and improve quality of life. We want to prevent blood clots to decrease the stroke risk, and that's why it's important you prescribe anticoagulation. We want to control the heart rate to allow the ventricles to have time to fill with blood. And we want to try to restore normal rhythm to follow the atrium ventricles to work together more efficiently. And by this, we'll do it medically or electrically through cardiac conversion. Management of AFib. So we're going to have them admitted on the telemetry unit. We're going to assess for emboli before we go through cardioversion. We want to use drugs to convert like amiodarone or disopyramide. We want to consider elective synchronized cardioversion if the ventricular rate is 120 to 200. Success of the cardioversion usually depends on the atrial size and the length of time they were in AFib for. Okay, obviously anticoagulation therapy is part of the management of it. And are they a candidate for the Watchman device, which is an implantable device? Okay, anticoagulation for AFib. In the patients, you want to do IV heparin. If they're inpatient, like in the hospital, we want to do IV heparin. We want to do a rapid anticoagulation and then start them on warfarin or Coumadin for about 5 days for full anticoagulant effect. The PT-INR is drawn and the patient is started on Coumadin, and then they adjust the doses based on the INR. So a target INR in AFib is usually between 2 and 3. The PT is checked at regular intervals to ensure that the INR remains within the appropriate range. Once a constant or consistent appropriate INR range has been achieved, the patient should be monitored monthly. Keep in mind that if the patient has difficulty getting out to appointments, that some patients' insurances will cover an INR machine that can be used at home, and then the patient will call the results in. But you want to be careful which patients you utilize that on. They have to really be able to do it and prick their finger, and you just have to give them a lot of education to make sure they're doing it correctly. Alternatives to warfarin we talked about before, dabigatran or Pradaxa. We have Xarelto and we have Eliquis. These are all management of patients with non-valvular AFib. The difference with these is that they have shorter half-lives, they have fewer drug interactions, and earlier peak blood levels. There's no dose titration or laboratory monitoring when you're on any of these, as opposed to Coumadin, where you need to get your INR checked pretty frequently. There's a 10% reduction in mortality. They have fewer strokes and systemic emboli. The disadvantage is there may not be an antidote to these, as opposed to Coumadin, where you can just go in and get some vitamin K. Chronic AFib is difficult to convert with a controlled ventricular rate, so you want to make sure they're on anticoagulant therapy indefinitely. And then cardiac ablation is considered if the prescription, the anticoagulant you prescribe, is not effective. Okay, anticoagulant options. So this is your chart of the anticoagulants we just spoke about: Coumadin, Pradaxa, Xarelto, and Eliquis. This is pretty much what's on the market right now. Some of these are expensive, like Eliquis and Xarelto. So you just want to make sure that the patient's insurance cost covers it. You want to make sure that you know what the reversal is. I mean, Pradaxa does have an antidote. Xarelto does not have an antidote, although they're saying there's one in development. There's no antidote for Eliquis, and there is the antidote for Coumadin. Usually Coumadin is still a high choice of anticoagulants for the simple fact that it's so cheap and there is an antidote. And then of course you want to consider the ease of treatment and avoid frequent blood draws. So those are your patients with high risk for, their skin is very frail and they can't really tolerate a lot of blood draws. They can't get out of their house that frequently. Like, those are the people you want to just try to put on the other easier managing anticoagulants. Okay, so with AFib, most of these patients will have some form of history of cardiac disease. Most commonly with your AFib patients, you've got the comorbidities of CHF, hypertension, or rheumatic heart disease. Usually AFib is precipitated by some acute illness, an electrolyte imbalance, major cardiac surgery, or a dilated right atrium or cor pulmonale. It also can be caused due to an abrupt discontinuation of beta blockers. When a patient stops drinking suddenly, they can also develop AFib. Hyperthyroidism and an acute MI can all lead to an atrial fib. Any type of surgery, not even just cardiac surgery, sometimes the after effects can be atrial fibrillation. So the big thing is we want to control the ventricular response and then convert the patient back to a normal sinus rhythm by using medications or electrical synchronized cardioversion. We want to treat these patients with a beta blocker or a calcium channel blocker. Now, in arrhythmias, in terms of diagnosing tests, referrals, and consults, it's pretty basic. You're going to get an EKG. Depending on the arrhythmia, you're going to go further with your studies, whether it's an EPS, tilt table testing, autonomic testing, a TEE. You definitely want to do a cardiac consult. I'm very leery of especially a new NP, even considering treating without going ahead and getting a cardiac consult. A lot of the times patients with AFib have multiple comorbidities, both, also in cardiac in nature. So you want to just make sure that this patient is being followed by cardiology. You want to consider Holter monitoring. Obviously, you want to get them on an antiarrhythmic, consider ablation, EPS, ICS, pacers. Obviously, if they are clinically decompensating or their cardiac output is falling, you want to obviously get them to the emergency room, initiate BLS and ACLS as needed. Okay, so this is a great slide because it keeps it pretty basic. So when we're talking about controlling the rate in AFib and arrhythmias, we want to consider beta blockers, calcium channel blockers, or digoxin. Remember, digoxin requires a lot of follow-up lab work. In terms of converting and controlling the rhythm, that's when you want to consider amiodarone, some beta blockers like metoprolol or sotalol. You want to consider calcium channel blockers like diltiazem. You want to consider Tambacor, Multac, or Ticosin. Okay, so ICS. So implantable cardioverter defibrillator, multi-programmable antiarrhythmic devices which are capable of treating Brady dysrhythmias, ventricular fib, and ventricular tachycardia. So it does like an anti-tachycardia pacing and defibrillating, and it gives you low and high energy shocks in multiple ranges of tachycardic rates. It's surgically placed under the skin of the left chest, and the patients need close follow-up with cardiology and extensive patient education. They should definitely carry a device identification card at all times. Okay, a symptom, syncope, right? What's syncope? Temporary loss of consciousness and postural tone that is followed by spontaneous complete recovery and does not require resuscitation. So basically they just passed out for a minute. Pre-syncope, well, before they actually pass out, they what they have pre-syncopal episodes is basically defined as a sensation of lightheadedness or faintness in which a patient senses true syncope is imminent, but it doesn't occur. So they feel dizzy and lightheaded like they're about to pass out, but they don't actually pass out. So those are called pre-syncopal episodes. Syncope is a symptom of an underlying process, obviously, and it's due to the lack of oxygen to the brain or the lack of nutrients to the brain. So causes of syncope, obviously, we're going to talk about cardiac causes, which can be mechanical and obstructive processes. And here's a list. It could be from the arrhythmias. It could be neurological in nature. A lot of the times we get vasovagal responses when patients are trying to have a bowel movement and they get into a syncopal episode where they pass out on the toilet. So you got to be very careful with your cardiac patients and reminding them not to strain when they're on the toilet, especially during a bowel movement. If they find that they're straining, they need to stop what they're doing, get off the toilet, get some, stool softeners, just make sure their bowel regime is on point and get them whatever medications they need to help so that they're not straining. Because, you don't want to have these syncopal episodes where these elderly patients are falling and hitting their heads. Then we'll really have some trouble to deal with. So then we have the miscellaneous reasons for syncope: hypoglycemia, hypovolemia, dehydration, and of course, any kind of panic issues, anxiety, and depression can also have that effect on people at times. So syncope evaluation, you need to do a detailed history of the incident. You need to determine if neurally mediated cardiac event or miscellaneous cause. Did the patient have any aura or positional changes or chest pain when they had this syncopal experience? Was there any seizure activity associated with it? Tongue biting? Are they on any medications? What's their past medical history, family history? Do they have any smoking history? You want to consider any coronary artery risk factors, like or they have hypertension, smoking, diabetes, those kinds of things. So you're going to do a full evaluation to make sure that this syncopal event isn't a precursor to something even worse. So you're going to do a full cardiac evaluation. You're going to do orthostatic blood pressures. You want to make sure they're not dropping when they stand. You're going to do a neuro exam. Just look for any etiology of why this syncopal episode may have occurred. Is there any nystagmus in the eyes, any headaches, any blurred vision? Really do a good thorough neuro exam, especially just to get a baseline on this particular patient. You want to do a rectal exam just to look for any blood or hemocult or any source of blood loss. If the patient has had a fall, it's important to differentiate. Did they slip and fall, or did they have a syncopal episode and fall? There is a big difference as the differentials and workup differ. That's very important. So remember that. If your patient falls, how did the fall occur? What precipitated the fall? Were they in the bathroom and they tripped on the rug and slipped and fell? Or did they actually get dizzy, lightheaded, and then fall because they were in the process of passing out? You really want to try to differentiate that so you can make sure your differentials and workup are appropriate. So in terms of a diagnostic workup for syncope, we're looking at an EKG, cardiac enzymes. We're going to look at their electrolytes, their BUN, creatinine, glucose, BNP. We want to do a chest x-ray. Do they have any walking pneumonia? Is there anything, any lungs that are collapsed? Anything going on in there? Any alcohol, history of alcohol, excessive drinking, drug screen you may want to do if you're concerned about any kind of recreational abuse of drugs. We want to look at their echocardiogram. We want to always consider pregnancy test if the female patient is of childbearing age. We may need to consider an exercise stress test. Again, that will be initiated by the cardiologist. We want to do EKG monitoring, possibly Holter monitoring at home. We want to do a tilt table test if necessary, an EEG, a head CT, an MRI, or a carotid Doppler evaluation. These are all possibilities depending on the severity, how frequently if the syncope has happened more than once, or if your EKG is showing you irregular rhythms. Okay, valve disease and murmurs. Okay, so we talked about murmurs in our last PowerPoint. We're going to go through them again. because this has a little bit of different information that I want to point out to you. So remember, diastolic murmurs are pathologic in nature. So if there's a new murmur, you're definitely going to consider acute failure, especially in the face of a recent MI. You want to think rupture of a valve. Okay, so murmurs are a sign that something has already happened, and now we're actually in a worse state. So if you hear a murmur, ask the patient if they've ever been told they have had one before you initiate a workup. And because they often forget to tell you when they're giving you their past medical history. So just ask the patient, like, has anybody told you you have like a funny beat in your heart? And see what they say. Valve disorders. We have mitral and aortic valve disorders are the most common. We have congenital or acquired, symptomatic or asymptomatic. They're usually detected during cardiac auscultations. And what you're going to see is alterations in the normal heart rhythm, a presence of an extrasystole, murmurs, abnormal heart sounds are usually heard. Subjective data includes fatigue, the patient's complaining of fatigue, dyspnea, chest pain, and syncope. Objective, you're going to hear the murmurs depending on which valve it's coming from. It may radiate across the precordium into the neck, which are signs of heart failure. In terms of diagnostics, we're going to do an echocardiogram, an EKG. We may see the chest X-ray. Blood work just depends on how the patient presents in terms of how you want to go forward with your diagnostics. In primary care, it's really important to determine if this is a new murmur. Like we said before, find out, ask the patient and then look in their charts to see if you have any evidence of a previous documentation of a murmur. So you want to, when you do discover a new murmur, you want to make sure you're describing it and if the patient is symptomatic and what your plan is in terms of consultations and treatment. If it's stable, and they're not symptomatic, you want to go send them for an EKG and an echo and then make referrals as necessary. You want to make sure any new murmurs that you're discovering on your patients or old murmurs that are progressing and the patient is symptomatic, you want to make sure you're referring to cardiology. Okay, cardiac murmurs, obviously we know they're due to an abnormal blood flow. They could be caused by congenital defects, trauma, ischemic chain damage, or degenerative changes and inflammation. All four valves can become diseased, but usually it's mitral and aortic. Okay, so it's usually these two that are the trouble valves. Valve openings either narrow, which is considered stenosis, or they don't close correctly and they become incompetent. So the cardiac valves and heart sounds. So here is a beautiful little visual description of what you're hearing with your different murmurs. I'm going to tell you this, you're going to need to go through each murmur and listen to the heart sounds, whether it's in your clinicals or whether it's on YouTube videos, wherever you can find good resources to let you just really review your heart sounds. You want to make sure you know the most common ones as listed here. Not only for the sake of your clinical practice, but to make sure you know them for the exam and your boards. Okay, you need to be able to recognize what they sound like and how to describe them. Oh, and where the location of where they are located when you have to go and do your assessment. So remember, in terms of murmurs, we are grading them from grade 1 to grade 6, and grade 6 being with the loudest with the thrill heard with the stethoscope almost entirely off the chest. So that thing is really bounding. So remember, we're grading them, then we're figuring out the location. Where in the cycle did you hear this? Systolic, mid-systolic, diastolic, etc. What's the shape? Is it crescendo, decrescendo, crescendo, decrescendo, or uniform? The pitch, is it high or low? The quality, is it harsh, rumbling, or blowing? Where on the chest wall? Does it radiate to the chest, axial carotids? Correlation with inspiration and expiration. This is a little mnemonic to help you with just recognizing where the valves sounds would be. Okay, murmurs. So many murmurs, like I said, become familiar with the most common ones in adults. Usually the etiology is congenital, could be bacterial endocarditis. It could have been rheumatic heart disease, calcification, papillary muscle chordae, tendinae damage, or rupture. My aortic and mitral valves murmurs are the most common. Others are less common. The symptoms are mostly the same for both. It's failure, heart failure, dyspnea, lightheadedness, chest pain, and syncope. And your diagnostics include, just like all of them, echo is usually first diagnostic done. TEE is more definitive, and then the cardiac cath is the most definitive. EKG is is just testing done on presentation, because it's the easiest, quickest way to really figure out what's going on in terms of what murmur we're looking at. Treatment varies depending on the valve it's coming from. So eventually valve disease progresses, which will require repair. So, that is what we want to try to prevent from happening with medication and treatment management. So again, here is our heart murmurs. And I love this little chart because it really gives you a clear view on what you're listening to, what the symptoms are, what the signs are, and what the causes are. So here we have very common ones: mitral stenosis, mitral regurg, aortic stenosis, and aortic regurg. Okay, so here are your common cardiac murmurs. These are the ones I want to make sure that you know how to describe and differentiate, no matter if you're in clinical practice or you're looking at your exam. Okay, so just remember that. We want to know aortic stenosis, aortic sclerosis, aortic regurg, mitral stenosis, atrial septal defect, pulmonary hypertension, mitral regurg, and mitral valve prolapse. So benign murmurs, let's talk about that. So a hemic murmur, there's no cardiac pathology, and you may hear in high flow states, for example, during like when a patient has a fever, they're exercising, and it's harsh and crescendo decrescendo in nature. Then you have your benign systolic ejection murmurs, where there's no cardiac pathology and it's early to mid systole, left sternal border. It's usually in children and thin adults, and a lot of the thin adults are usually asymptomatic. Aortic sclerosis murmur, 50-50, meaning 50% of adults are likely, it's likely due to fibrotic and or calcific changes. Okay, aortic valve stenosis. So it's very commonly associated with advancing age, and in this, the AV fails to open and let blood into the aorta due to the calcification. It causes a diminished left ventricular outflow, and the symptoms include angina, syncope, exercise intolerance, dyspnea. You're going to hear a loud systolic ejection murmur, or a single split or split S2, and it's heard at the second RSB, which radiates to the second LSB and the carotids. The treatment includes relieving the signs and symptoms of angina, syncope, and heart failure, monitoring with an echo. You want to just really look at their risk factors and modify them accordingly, including with their cholesterol and their hypertension management. You want to consider valve replacement, and you want to be very careful with nitrates, because nitroglycerin in aortic valve stenosis can cause profound hypotension. So, okay, aortic valve regurgitation. It allows blood to regurgitate back into the LV during diastole due to scarred leaflets or enlargement of the valve orifice. This is common in hypertension, trauma, Marfan syndrome, congenital abnormalities, infective endocarditis, and rheumatoid arthritis. So symptoms are often asymptomatic for decades, and then they may present with left ventricular CHF signs like dyspnea on exertion, fatigue, PND, or orthopnea. And the S3 heart sound is a diastolic murmur. The treatment includes digitalis, diuretics, and arterial vasodilators, and aortic valve replacement if the patient is symptomatic. Mitral valve regurgitation and incompetence, which is incompetence of the closure of the mitral valve, which results in left ventricular stroke volume divided between aorta and reflux back into the left atrium, which puts them at higher risk for AFib. Okay, symptoms, again, may be asymptomatic for decades. Eventually they start to develop fatigue, dyspnea on exertion, CHF, palpitations, and later on AFib. The very classic sign of the mitral valve regurgitation or incompetence is assessed as pansystolic blowing murmur heard at the apex with a radiation to the axilla. That is your definition right there of what you're going to hear when you listen to a mitral valve regurgitation. The treatment is focused on symptom relief. So we want to deal with the left ventricular failure. We want to manage the dyspnea and the paroxysmal nocturnal dyspnea and the orthopnea. A lot of these patients do really well in electric recliners, especially at night. So the patient may want to consider getting one of those just to help with their quality of life and sleeping and being more comfortable. You want to prescribe and treat if they have AFib. You want to do anticoagulants. If they are symptomatic with heart failure, you want to definitely talk to them about sodium restriction and diuretics. And then, of course, you need to consider a surgical replacement of the valve if it becomes very severe. So mitral valve stenosis, classifications of the mitral valve. is 1 out of 3 patients over 75 years old. Most commonly, it's due to rheumatic fever. It's less common due to GABHS. And it happens because the mitral valve fails to open and let blood into the left ventricle, which results in a backup to the left atrium and pulmonary congestion. Symptoms include dyspnea on exertion, fatigue, palpitations, hoarseness, and angina. So we want to treat to relieve the signs and symptoms of decreased cardiac output and pulmonary congestion. We're going to be treating with loop diuretics. We're going to get our rate controlled, especially in AFib. We want to do anticoagulant therapy, again, if they have AFib, and antibiotic prophylaxis as needed. So when somebody has a mitral valve prolapse, that's when the protrusion of the mitral valve goes into the left atrium during systole. And classically, again, one of those things you need to memorize, what you're going to hear in this particular patient on a mitral valve prolapse is a mid-systolic click followed by a late systolic murmur, which is heard best at the apex. Okay, super important. It can be familial, it can be linked to Graves, scoliosis, Marfan's. You want to rule out if pectus excavatum and other signs are present. A lot of the times you're going to see this particular diagnosis in thin, tall females. Mitral valve prolapse tends to be in thin, tall females, okay? These patients are higher risk for AFib, TIAs, and ruptured chordae tendineae. Besides general murmur symptoms, they may have dyspnea aggravated by heavy exertion, orthostatic hypotension, and atypical chest pain. You want to treat with palpitations, you want to use beta blockers, however, it can cause increased fatigue. So definitely try to avoid stimulants because we don't want to make their arrhythmias worse. Murmur management and resources. So there's some more places to click on if you wanted to really get more into the actual sounds of the murmurs. Definitely Shadow Health gives you a lot of help in terms of reviewing murmurs and recognizing them. So use that to your advantage. You want to have this under your belt before you move on to the next semester. Trust me, this will come back to haunt you. Infective endocarditis, it could be bacterial or fungal infection in nature. It's usually gram-positive with Staphylococcus aureus or Streptococcus. A lot of the times you're dealing with patients who are IV drug abusers, or they have underlying valve or heart disease. They may have a prosthetic valve, or they may have had recent dental or surgical procedure. Okay, so if it's an acute infective endocarditis, we're looking at patients with a high fever, myalgias, night sweats, arthralgias, headache, and general malaise. If it's subacute, they're more likely to present with a low-grade fever and progressive non-specific symptoms. So if you're suspecting infectious endocarditis, things you need to look for are fever, chills, and malaise, and some other unique findings may present, like Janeway spots, which are tender red spots on their palms or soles. We have Osler's nodes. We have subungual splinter hemorrhages, and they may have a murmur. So if you see these little funny lesions, you definitely want to consider infective endocarditis and refer to cardiology or the emergency room for IV antibiotics, blood culture, CBC, and an ESR. I would definitely recommend that you remember these two particular atypical findings and how they're associated to infective endocarditis. So infective endocarditis prophylaxis. So it does have a high mortality rate, so it's really important you identify it early. No longer do we recommend MVP unless they have a history of bacterial endocarditis. We definitely want to look if they have any high-risk conditions requiring prophylaxis, like if they've had a history of IE, if they have any history of congenital heart defect, whether it's been repaired or not, if they have a history of cardiac transplant or any prosthetic valve replacements. These are all high-risk conditions requiring prophylaxis. You want to see guidelines for prophylaxis of bacterial endocarditis. 1 hour before the procedure, you definitely want to be doing the amoxicillin 1 gram, or you could use clindamycin if they have a penicillin allergy. You want to give that prior to any pre-dental cleanings because they're at a higher risk for bacterial endocarditis. And you want to make sure if they're having any invasive respiratory procedures involving incisions or biopsies, again, you're treating them for prophylactic bacterial endocarditis. Okay, so pericarditis, what is that? It's just that simply it means inflamed pericardial sac. So the sac around the heart is inflamed. It could be precordial or retrosternal on the left side, radiate to the neck, shoulder, trapezius ridge, dyspnea, especially when laying down, low-grade fever, tachypnea, cough, dysphagia, weakness, fatigue, dry cough, abdominal or leg swelling. You may be able to hear a pericardial rub. In this particular, or you may need to do a pericardial rub. You may, in terms of diagnostics, we're going to see EKG changes. You may see a new widespread ST elevation or PR depression. Consider etiology of pericarditis. It could be idiopathic, it could be viral, bacterial, it could be tuberculosis, inflammatory, hypothyroid, renal failure, acute MI, Dressler syndrome, aortic dissection, cancers, drugs, cardiovascular procedures could have led to this, or of course, trauma. The diagnostics you want to be ordering are EKGs, echoes, chest x-ray, lab work, CBC, ESR, metabolic, thyroid, cardiac, anything you want to consider depending on the etiology, the suspected etiology, especially with trauma. You obviously want to make a cardiac referral to a cardiology. You want to consider treating with aspirin, NSAIDs, and colchicines. You want to avoid using steroids unless needed for underlying condition. So a pericardiectomy is the most effective for managing large effusions and the lowest associated risk of recurrent effusions. So we use that for constricted pericarditis, effusive pericarditis, or recurrent pericarditis. It could be also used with people who have a steroid dependence and or intolerance to other medical management. The pericardial window placement is used for effusive pericarditis therapy in critically ill patients, where a balloon catheter is used to create a pericardial window. And then the other big thing you need to make sure is you're watching for cardiac tamponade. And that's it, guys. That's enough for 1 week for sure. A lot of information in the cardiac realm. So anyway, I hope this was helpful, and I will see you guys next week. Thank you.